afternoon, everyone. My name is Sharon McKinley, and I'm the Senior Consultant with NRC for In-Home Services, which, of course, is funded by the Department of Health and Human Services, Children's Bureau. So on behalf of the NRC for In-Home Services, I would like to welcome you to Promoting Safe and Stable Families Peer Learning Call today. Today's topic is on trauma-informed practice in child welfare services. Before we get started, we always like to go around and see who's on the call, since this is a peer learning call. So starting, I guess, from the east to the west, could you state who you are and what state you're representing?
Hello. I'm a western state, so I'm waiting my turn. But I'm Marty from Utah.
Marty from Utah?
Mm-hmm. Karen Regula from Iowa.
Oh, hi, Karen. Okay, Karen.
You have Gary King from West Virginia.
Okay. Okay, anyone else on the east side, or anyone from the east side, east coast?
Hello, this is Anthony Ellis from Louisiana.
Louisiana.
Okay.
And this is David Thompson from Minnesota.
Hi, David.
Hello.
All right. Okay, we're just announcing who you are and what state you're from.
Is it Sharon?
Yes.
Hi, this is Curtis Smith. When I heard you announce that you wanted the East Coast to stay who they are,
Yeah.
I accidentally hung up. So this is this is Curtis Smith from Virginia.
Well, I'm glad to hear from you, Curtis. I haven't talked to you in a while. Thank you for joining us today.
You're welcome.
This is Jay Dexter from Arizona.
Dexter, hi.
Hi, this is Maria Hickey from Nevada.
Okay. All right. Anyone else from, I guess, the West Coast, Midwest, East Coast?
Richard Lincoln, Alaska.
Welcome, Richard from Alaska. I think I could do this like that. Okay. All right. Well, if there are anyone else that want to announce and state where you're calling from.
Yeah.
Okay. Well, we want to thank you all for coming on, and hopefully that you'll get something out of today's call. Before I introduce our, hello?
It's Kevin Higgins from Montana.
Oh, hi, Kevin. Thank you for joining us. Okay. So before we get started and I introduce our presenter, we want to make sure everyone can hear. And so if you can you please mute your phone so that we will not hear any background noises. And to do that, you just hit the *6. And then we will allow time at the end of our presentation for questions and comments and that sort of thing. And then you can *6 to unmute your phone at that time. We will be sending out the materials through email, and it will also be posted on the NRC for In-Home Services website once it is available. Also, everyone, it's very important that at the conclusion of the presentation that you complete our little monkey survey monkey that we send out. It helps us to be able to plan for future events, that sort of thing, and to make sure that we are staying relevant to what your needs are. So I'll be sending an email out hopefully at the end of the presentation. Okay, so having said that, I want to introduce to you our presenters for today. First on our list is Jeannie Chrysler, and she is from North Carolina. And from there, we have also, I'm trying to find, oh, here we go. Sorry about that, everyone. She is from North Carolina Department of Health and Human Services. She's the coordinator for the project broadcast in North Carolina and in its efforts to develop trauma-informed child welfare system. And then we also have from Montana, we have James Kamunji, and he is the associate professor and at the University of Montana School of Social Work, as well as the co-principal investigator for their project that they're doing within Montana that they're going to be discussing. I'm going to put all their bio on the website because they have a lot of information here. And then we also have he has a whole team along with him as well. And I'm going to let him introduce them. We talked with Dr. Cousteau, as well as Marilyn Rouillet Zimmerman. That's also going to be talking with you as well. And then we have from Connecticut, Marilyn Cloud, and she is the Behavioral Health Clinical Manager at the Connecticut Department of Children and Families. Jason Lang, who's our Associate Director for their project. And then also Christian O'Connell, that will also be on there, and Cindy Cousteau, who will be on there, who will be a part of their project. So what I'm going to do right now, I'm just going to make sure that we we have a polling question before we get started. We always like to do something a little bit different. And so okay, we are having technical difficulties. Give us for a minute now. We're trying to. Okay. Okay, we're not going to be able to do what I'm hoping we was going to be able to do. So we're going to go back to our presentation. So let's go ahead and excuse us for that. I'm going to go ahead and let Jeannie Chrysler, you go ahead and do your presentation, and we'll try to figure out this polling thing later on. Okay. Thank you.
Thank you. Good afternoon, everyone. Thank you, Sharon, for inviting me. I think the polling question was about how are you familiar with trauma-informed practice? And I know, kind of like most child welfare agencies in the country, you know, we are all kind of moving in this direction. So North Carolina is similar and on a mission to become more trauma-informed. So I'm going to just share a little bit about how we got started and what we've been doing and some of the lessons that we've learned, in hopes that it somehow kind of helps you guys. We just appreciate your time today. So a few years ago, North Carolina was part of a breakthrough series with the National Child Traumatic Stress Network. And at that time, we were testing some trauma-informed practices like screening, and we just learned a great deal. And then we were fortunate to be selected as one of the 5 original sites funded by the Children's Bureau. And our grant, which we refer to as Project Broadcast, has really allowed us to be creative and test new ideas and really begin to develop a comprehensive, sustainable program. So the funding from the Children's Bureau, you may know, is for 5 years. 2011 was the first year, and that was a planning year, and now we're finishing up our second year. And the North Carolina Department of Health and Human Services has 2 key partners on the project, University of North Carolina at Chapel Hill, who's conducting the evaluation, and the Center for the Study, the Center for Health here in Durham, and it's a National Child Traumatic Stress Network site, and they are really our experts on the project. And I think one of the key lessons that we've learned so far is that we would not have been nearly as successful if we did not have strong partners at the table. I've been a part of a lot of projects in the past, and this one is just seriously strong kind of collaborative effort, and it's been an amazing example of kind of having that mental health, the child welfare, and data, and how all those things really align for the common goal of promoting child well-being. And Sharon, just so you know, I'm looking not at my slides at this time. I don't know if the other participants are. We're just.
You can tell me when you want me to the next slide, because I haven't moved anything.
Right. I'm just looking at the peer learning call, the main screen, so we can move it, I guess. So anyway, so North Carolina is one of the few states in the country that is county administered and state supervised, which is a challenge sometimes when you're starting to initiate a new program like this. We actually selected 9 out of our 100 counties to start this project in. It's a good mix of demographic populations, and one even has a military base. And these counties were selected because they're doing work with us on a continuous quality improvement initiative, and that initiative really focused on using data to drive decision making. And we felt, and still do, that being trauma-informed is rooted in knowing data, that knowing this information, what the child's been exposed to, the results of a comprehensive assessment, that information was really key.
Jeannie, I'm sorry,
yes.
This is Sharon. I'm trying to follow you because right now I'm at your 5 strategies. So
that was still on the main screen, but I'm not seeing anything. Are the participants seeing anything? Because I've just got. I don't think they are either.
No, we're not.
You're not? Hold on. Oh, hold on. Are you all seeing that?
There we go. Okay. So now you can go to the next screen.
Okay. I was going to say, well, why didn't I see that?
That's our fancy logo.
Hold on.
Okay, so we organized ourselves within these 5 strategies, and we felt like if we could tackle these broad goals, that we would be well on our way to being a trauma-informed system. So the first is develop a trauma-informed workforce. The second was to increase the number of clinicians who are in our state that are trained in treatments that are evidence-based and trauma-informed. The third is to increase the public's access and even the child welfare professionals' ability to access who those trained clinicians are. And we really wanted to work across all child-serving agencies to share data in a meaningful way, and then finally to look at our policies and to make them more trauma-informed. Next slide. So we spent a large majority of this year in developing a trauma-informed workforce, and for the purposes of this project, we defined it as child welfare staff, as parents, as foster, adoptive, kinship, therapeutic folks, and then the more general system of care providers, our law enforcement, domestic violence agencies, courts, and that kind of thing. And so one of the more innovative things that we tried was using the National Child Traumatic Stress Network's product. You may be familiar with this Child Welfare Trauma Training Toolkit. It is a 2-day curriculum designed specifically for child welfare staff, But instead of doing it over 2 days, we've trained it using the NCTSN's learning collaborative methodology. So we've trained it across 6 days, 3 2 face-to-face sessions. And we spread that over the course of 9 months. A little bit of feedback on potentially your phone there. So we brought teams together from each of the counties. Teams had 7 to 10 people, depending on the size of the county. And they had to include a senior leader with decision-making ability, a supervisor, and a frontline staff. And we even brought a team from the state office together for these learning sessions. One of the key things we learned in our CQI initiative was that this culture shift to be trauma-informed really has to happen on all levels. And so we felt like it was really important to have a state team there hearing the same information and processing what it means for us at the state level while the counties were processing the information at the child kind of practice level. So by spreading this out over 6 learning days, we were able to add material where needed and give teams a chance to really dive deep into the material and figure out what it meant for them on a real practical and often child case-specific level, you know, how to be really trauma-informed on a practical level. And so we also, by spreading it over the 9 months, we were able to provide regular consultation to the teams, whether that was telephone or in person, and help them implement the trauma-informed practices in real time and help them spread within their agency. So we actually designed the learning collaborative around 46 really key elements, but each of the teams, in between these learning sessions, we had these action periods, and we really honed in on some key areas. Certainly the first was screening for trauma. We did not have any screening for trauma in North Carolina other than kind of our general safety assessments, which certainly got at it, but not with that laser focus. And we paired that focus with screening with secondary traumatic stress. We had learned through our breakthrough series just how critically linked these two pieces were. Certainly one of the key tenets of a trauma-informed system is that we're taking care of the caregivers. So we really focused on this first. And, you know, historically, secondary traumatic stress just tends to be an afterthought. So we just made a concerted effort to make it a primary focus. And then we also had teams focus on psychological safety and working with youth and parents and partners as another kind of key focus. And so what we initially found from a lessons learned perspective is that, you know, a lot of these child welfare professionals felt like they were already doing trauma-informed work. You know, they live and breathe this trauma kind of day in and day out. And so it took a while to make sure that this wasn't kind of seen as just another initiative, or that it wasn't just a buzzword. And what happened was it took some time for these teams to realize they didn't know as much about trauma as they thought they did. You know, so that was kind of one of the big things. And the other was, I know as a nation we've discussed kind of redefining well-being and what that means in our kind of safety, permanence, and well-being model. But we're also redefining safety to include not just that physical safety, but also that psychological safety. So that was a big shift for many of these people who have been doing this work for a long time. So we tried to mold the whole process in implementation science principles. So the selection of actually who came to the Learning Collaborative was carefully done. We embedded that regular coaching for each of the teams, helping those teams overcome system barriers, and really feeding them back data on what they were doing and how that was molding their system. So we know trauma-informed practice as a real cultural shift. So we didn't want to just do training alone so we can really help sustain this. So we have just concluded the Learning Collaborative, and while teams felt it was really difficult to have a team from their agency out of the office at the same time, they also indicated it was very important and extremely beneficial for them. So we're kind of crunching the data now to determine if this model is what we want to use kind of moving forward to our other 91 counties, or if we want to tweak it somehow. So we're moving and learning about what we want to do now. So that second bullet there, you see we're using another product from NCTSN called Caring for Children Who Have Experienced Trauma, and hopefully you know about this curriculum. It is a pretty powerful full resource families. One of the counties that has been using it has mandated it as part of relicensure. So we are really focusing on sustaining this within the county. So as we are delivering it, we are also training child welfare professional in each of the counties to be able to sustain it kind of moving forward. And that third one there, our final kind of a big approach is to developing this workforce is to basically blast the word out as far and wide as we possibly can. We've leveraged other funding to hold these one-day trainings in each of the counties, and so over 1,300 people attended these trainings, and it's really helped the counties kind of begin to have that common language with their system of care providers and really focus on being kind of community achievement focused. We've also have a trauma summit each year, which bring together leaders from the state to update them on what's happening and get more buy-in, more people involved in this trauma movement. And we've really tried to weave it into our fabric as much as possible, so all of our newsletters and other kind of training initiatives, we just try to weave it in. So next slide. Before we move off this very first strategy of workforce development, I wanted to kind of give you a sense of what we're doing with our screening. So we've developed our own form. We've borrowed shamelessly from other NCTSN products, but we felt in North Carolina it had to be a one-pager. That, you know, adding anything to anybody's workload, it just had to be a one-pager. So the tool has 6 primary components, certainly in kind of that basic demographic information. We want to make sure we capture all of the potential traumatic events that the child might have been exposed to, as well as the trauma symptoms or behavioral concerns. And then we learned the value of asking the children directly about what happened to them. And so we've included these 4 questions. If the child is over 6 years old, we are asking them directly. And then we're certainly documenting the decision about screening and the action taken. So the next slide tells you what those 4 questions are. I'm really getting feedback. Yep. Yeah. So rooted in some of the questions from the UCLA, PTSD, RI, but we're basically asking them about physical abuse, domestic violence, sexual abuse, and then we have this kind of catch-all question about tell me anything else that's scary that's ever happened to you. And we really have tangible examples now of cases that would have otherwise been closed, that the worker said, oh, I forgot to go do this trauma screen, and they've gone in and asked these questions, and the information revealed actually warranted a removal. But the answers to these questions have been powerful. So we know that there's kids who will not disclose about having a relationship, but we also know that just asking the question is also an effective disclosure mechanism. So we're training teams on how to do this and doing role plays around it so they get comfortable with it. And so we're excited about this direction. And so that all is kind of in that big first category of trauma-informed workforce. Next slide. The second strategy is increasing the number of clinicians trained to do this evidence-based or evidence-informed treatment models. And so we've selected these 4 models you see here, primarily because they met the needs of our kids in our demonstration counties, but also they each had a parental component, potentially aside from Sparks, who's that teen model, but and they also gave us this range of age coverage so that we could have the ability to kind of plug kids in when we needed. So we are currently gearing up to conduct our ABC Learning Collaborative now, and a few of our counties are the actual DSSs, as opposed to the mental health side, are adding this to their toolbox for in-home services. So this is where we feel like from an in-home model, the more tools you have and resources you have, the better. The sooner that we can address these attachment issues, hopefully can prevent things from happening in the future. Next slide. So one of the key things is that it's important to us that they're not just trained, but that we actually know for sure that they're capable of doing the treatment with fidelity to the model. So in North Carolina, we're extremely blessed to have this child treatment program, which it uses that learning collaborative methodology to train clinicians, and they make those clinicians, take a few cases. I know people are doing this across the country too, but one of the things that this treatment program does is they have a really high bar, even more so than the model developers, to kind of make sure that these clinicians can do it. And so if they are assured that they can, then they become rostered, and you can go to this website and find a rostered clinician. So right now that treatment program is about the cognitive behavioral therapy, but we'll be expanding it to the other models. Next slide. So next is our increase our ability to share data, and this is huge, monumental. And it could be really as simple as the therapist sharing a trauma trigger with the child welfare professional, or as complex as really sharing Medicaid claims data and juvenile justice data and all the things we currently are not really in sync about. We did develop as part of this a process where the county can call a pharmacist and learn immediately what meds the child is on, what diagnosis they're in, what physicians they've seen. So if we take a child into custody and we're not able to get a good history on the child for whatever reason, we'll know immediately if there's some meds we need to get filled, asthma medicine, for example. And this has really helped avoid kind of unnecessary hospital visits and been a nice kind of backstop for our whole system. And then looking at our policies and procedures, much of this will be done kind of at that county level, but there's several statewide policy implications for what we're doing as we're moving trauma screening statewide and really implementing this. So it's been we're very excited about where we are. We've, again, spent that second year really focusing on the workforce development and the next 3 we have here. We'll be kind of really embedding this into the other 91 counties and looking at data and policies and procedures and all that. So next slide is my contact information, I think, and if anybody has any questions, certainly feel free to kind of connect with me as we move forward, and I appreciate you allowing me to come today.
Thank you, Jeannie. We're going to go now to Montana, and Jim, you want to take over?
Hello, everybody. This is Jim Karinji. It's a pleasure to be with you today with my colleagues, and I will introduce them now. We're going to split up our presentation. Marilyn Breer-Zimmerman is the director of the National Native Children's Trauma Center, and the co-principal investigator of this grant, Rick Vandenpaul, is with us, and also he is the director of the Institute for Educational Research and Service, which houses the National Native Children's Trauma Center.
Thanks, Jim. If it would be possible to scroll the slide up just a little bit on the screen, people would be able to see. I've been asked to provide just a very brief context for the work that we're doing, attempting to transform child welfare in Indian country so that it is more trauma-informed, is characterized by trauma-informed practices among child protective service workers and other child welfare workers, so that the services that are provided reflect evidence-based practices. The host institution for this cooperative agreement is the Institute for Educational Research and Service at the University of Montana in Missoula, in the far western part of the state of Montana. We're working with 3 sites in eastern and southeastern Montana, the furthest of which is literally an 1,100-mile drive round trip on 2-lane roads. Our institute is explicitly interdisciplinary. We draw upon faculty from the School of Social Work, Department of Psychology, College of Education, Educational Leadership, and Counseling and Speech Pathology. We also have individuals who have professional expertise in law enforcement, child protective services, clinical psychology, and other disciplines, not necessarily part of an academic department. The Institute has existed lot of our work, including the cooperative agreement with the Children's Bureau, involves sovereign nations in the state of Montana. This slide depicts our major reservations, the Flathead on the far west, Blackfeet slightly north of that, the Rocky Boys Reservation, north central Montana, adjacent to Fort Belknap, and then on the far east, northeast corner of the Fort Peck Reservation. Fort Peck is one of our partners on the Children's Bureau Cooperative Grant, and at the lower part of your screen, adjacent to one another and contiguous in boundary, is the Northern Cheyenne Reservation and the Crow Reservation. Finally, the star in the middle of the screen is the primary location of the Little Shell tribe, largely an urban native tribe in Great Falls, Montana. Can I have the next slide, please?
Hi, this is Marilyn Breyer-Zimmerman, and I am an enrolled member of the Fort Peck Assiniboine and Sioux tribes from that reservation that is in the far northeastern corner of Montana that you saw on the last slide. And I'm going to briefly describe how we work with tribes around the nation, but in particular with our three partners, the Crow, the Northern Cheyenne, and Fort Peck reservations. We have a position paper that you're looking at, a part of it on this slide, and this position paper is basically about how we build relationship with tribes. But I wanted to begin by saying that child welfare in Indian country is incredibly complex. The system serving children and families in Indian country, which Indian country is any reservation in the United States or any urban center where there's a large native population. For example, there is an urban center here in our university town of Missoula, and the school districts here represent 3 different tribes. So the local urban center is an important piece of what Indian country is nationally. It's a perfect example of what that is in an urban setting. Anyway, it's very complex. So there are state systems that serve tribes that do not have the capacity to have their own tribal welfare child welfare systems. There are child welfare systems that tribes have. They create and fund and manage their own tribal systems. And then there is the Bureau of Indian Affairs, and we are working specifically with the Bureau of Indian Affairs on the Crow, Northern Cheyenne, and Fort Peck because they are the direct service tribes for that federal person. But also what creates even more complexity to the issues of child well-being in Indian country is the fact that when we're talking in Indian country about what a trauma-informed child welfare system is, the tribes themselves are asking us to include always as a part of any strategy around training, capacity building, assessments, to include law enforcement, to include the tribal councils, to include the Bureau of Indian Affairs superintendents who are the leadership at the local levels, and to include if there's state child welfare in the region anywhere. For example, on the Crow Reservation, there's a state agency that's just on the border of the Crow Reservation in the community of Hardin that is a part of a lot of and serves a lot of American Indian children because it's a border town. So they become a part of our conversation around what is a trauma-informed child welfare system. As you can see by the slide, we are very cognizant of the history, the poor history that universities have working with tribes. But I want to say that we do not pay lip service to the reality that tribes are sovereign nations. We always honor that sovereignty. We have make sure that our sponsors always know that any research data belongs to the tribes. We've been able to, for the last 12 years, been able to honor that. Tribes are very willing to share data, especially when outcomes of well-being for their children are helpful. So we've never run into a problem yet, but we always let them know that we honor that. Next slide, please. And then I think a big piece is just going in through invitation only and just really having insight and understanding that the communities know what they need. and we follow the leads of the community always. Even before we wrote the grant, we had to develop the partnerships with the Bureau of Indian Affairs Child Protection team at the regional level, and then they had to introduce us to the local site folks, and we had to discuss the possibilities of what could be accomplished in this project, what some of the basic needs were, and so before we even wrote a single word, we had that relationship developed. And then finally, along myself included, because I am a member of a particular sovereign nation, does not necessarily mean that I understand the cultural nuances or the specific community needs of another sovereign nation. So we take it very seriously that non-Native practitioners working in Indian country need to understand and promote wholeness of the child and wholeness of the family. So next slide. Next slide, please.
Thanks, Ron. If we could scroll down just a little bit, this map depicts the work that our trauma center under Maryland's direction has been performing for the period May 2010 to presently. So most of our work, as you can see, is peppered in the state of Montana, with additional work occurring North and South Dakota and across the upper Midwest on into Minnesota. We have additional sites that we have conducted training, dissemination, and technical assistance on the east and west coasts, and some in the southern and eastern coasts. We're currently trying to recruit opportunities to work, particularly in Southwest. Not visible to the slide for some viewers, we have aggregated the total number of travel days, and they actually come out to about 2 persons traveling per day of the calendar year, including weekends. So there's a lot of windshield time and a fair amount of airport terminal time that my colleagues endure in order to try to have the national impact that is required, less by the Children's Bureau grant at this time and more by the mission of the National Native Children's Trauma Center under Maryland's direction, which is funded by, as a Category 2 Treatment and Service Rehabilitation Center of the National Child Traumatic Stress Network.
Thanks, Rick. This is Jim. I'm going to now describe briefly the overall goals of our project and objectives and what we're specifically trying to do with both the Bureau of Indian Affairs and the Indian Health Service. So our project is entitled Transforming Tribal Child Protective Services, and our main goal is to create a trauma-informed systems in the Bureau of Indian Affairs, BIA, and also Indian Health Services, IHS. To that end, we are implementing evidence-based trauma interventions in BIA and have a plan to in IHS. Finally, we would like to create a replicable system that could be used, and I want to stress adapted in other tribal communities, because each tribal community, even here in Montana, is very unique, and there would need to be adaptation. Just to give kind of a picture, I know our colleagues in Connecticut, North Carolina are talking about child welfare systems that have many, many workers. In contrast to that, we presently have 12 local BIA workers now working in our 3 tribal partner communities. We have 10 that have either resigned or left in the last 2 years, with an overall end basically of 22 for our target system for the Bureau of Indian Affairs. In terms of the numbers that are served in our agencies, we're seeing in one of our partner sites 200 kids approximately, and as many as double that, 400 in another. So you can see that we're working against some very extreme deficits in terms of resources. In terms of our BIA work, we are implementing an intervention called Design Teams, which is from a previously funded Children's Bureau effort that I've been involved in with others. In this intervention, we are using design teams as an assessment tool and a collaborative assessment tool to figure out where the systems are in terms of readiness, what interventions would be appropriate, and how to move forward in a way that would make most sense for them such that these interventions would be value added, which is something that's very important to our work. Like our colleagues in North Carolina, we also found that it's very important to do work regarding secondary traumatic stress, and to that end, both with the Bureau of Indian Affairs and Indian Health Service, we feel that addressing secondary traumatic stress in a personal, professional, and organizational manner through an intervention that we're developing that we refer to as the secondary traumatic stress intervention is important, and that's work that we're completing, and well, it won't be completed, it's ongoing. We are also using the Child Welfare Trauma Toolkit, the second version, and that's actually something that was developed by the National Child Traumatic Stress Network as well, and we are further working to adapt that for Indian countries. So that's something that Maryland's been involved in that's really important. Our final intervention with BIA is Attachment Self-Regulation and Competency, or ARC. That is a means of creating trauma-informed systems that's been used in schools and also in child welfare, in which it helps the worker and also potentially parents recognize trauma symptoms as opposed to just negative behaviors. Next slide, please. In terms of the Indian Health Service, I mentioned that we're also working with we plan to work with secondary traumatic stress intervention there. Our intervention of choice is MAP, which stands managing and adapting practice. Thank you, Rick. And the reason we like MAP is because it is a modular intervention. We find that Indian Health Service is equally in difficult circumstances with resources, and the average number of times that an IHS worker will see a kid is about 2, so maybe 2 to 4. So doing long-term interventions that are looked at as short-term in other places, say like CFT, that requires 12 to 14 interventions really aren't going to take here. So MAP is a way for us to be able to move forward with an evidence-based practice or an evidence-informed practices. Next slide, please. That's us. Beautiful campus of the University of Montana. I would just say what a pleasure it is to be with you all today and to be working with such a great group of colleagues in cohort 1 and 2 for this project, and we're just so grateful to the Administration of Children and Families and Children's Bureau for this funding that's allowing us to do this important work with some very, very strong and also needy communities that are our partners. Thank you.
Thank you so much, Jim. I appreciate that. And we are going to move on to Connecticut, and Maryland Cloud will be presenting. Thank you.
Good afternoon. This is Marilyn Cloud. Thank you for inviting the Connecticut team to share what work we've done today. I'm going to talk very briefly about our project. We have 3 primary objectives. First is increase the capacity of our frontline social workers and supervisors to identify and respond appropriately to children who have experienced traumatic stress and connect them with evidence-based treatment. A second goal is to enhance access to evidence-based trauma-specific treatment. We've identified both TFCBT and a short-term prevention treatment. I'm sorry, could you advance the slide, please? Sure. And a short-term treatment dissemination of child and family traumatic stress intervention developed at Yale University. And our third goal is based on feedback that was unanimous from the frontline staff that asked for some real concrete supports in helping them to reduce and prevent secondary traumatic stress. We have 5 primary project activities. These include, as the other states have done, advancing workforce knowledge and skills in case practice, also finding ways to develop a trauma screening tool and make sure that there are connections with mental health providers, we will be further disseminating 2 evidence-based practices, as I mentioned, TFCBT and CFTSI. Another key component is evaluation of all aspects of the grant, including processes, costs, child, family, and system outcomes. And we really should add a 6th primary activity here, which is ongoing review of all relevant child welfare practices and policies. We have 2 critical partners, the Child Health and Development Institute, who Jason Lang is going to speak next, and he's the co-principal investigator, and the Consultation Center at Yale University, who serve as our evaluators. Next slide.
Hi, everybody. It's Jason Lang. I'm going to talk very briefly about our work in trauma screening, and specifically about some of the strategies and lessons learned from the past year and a half, 2 years, in terms of developing a standardized trauma screening tool and process for child welfare. And one of the biggest challenges that we've had is really to think about where does trauma screening fit in the universe of child welfare practice, looking at other assessment screening tools, evaluation procedures, and the workflow of CPS staff to identify the best place or places to include trauma screening, what the measure should look like, and how it should really be integrated into casework practice. So we've also, through the ACF grant, have had a planning year to think about these things and actually continue to do much of that work now, with the goal being that we will have a standardized screening tool and process in place during the grant period. So we've looked at who needs to be involved and what systems need to be involved, and that includes everything from input from workers and supervisors and administrators, but also things like information systems, policy folks, the mental health providers in the community who will be affected by trauma screening and child welfare, and the referrals that will generate. And so we've been working with a diverse team of many of those folks to think about the screening tool and process. We've also really thought a lot about what services are available for children who screen positive and how that might impact trauma screening. As Marilyn mentioned, we have made a lot of progress bringing trauma-focused CBT to Connecticut providers, and that's probably the most widely available practice that's available in most of the state, but there are some others around that we hope to expand further through this grant. So when workers use the screening tool, we want to make sure that they're connecting children with the most appropriate practices. And then the last bullet really for us has meant thinking about state and federal laws and other things that must be considered with trauma screening. Other states have had some challenges around union issues. In Connecticut, we've been under a federal consent decree for not meeting some needs of children for more than 20 years now, and so developing a screening tool, we want to make sure we're not going to impede progress in that, and hopefully assist with progress in meeting those goals. Next slide, please. During our planning year, we did a lot of focus groups and meeting with child welfare staff and others around the state, and some of the feedback that we got was really that our screening tool had to be brief, as short as possible. Workers really have a huge amount of tools and assessments and screens that they already do, and that they were sometimes reluctant to add another thing to that list. We also heard that workers are not clinicians, and that anything that we use for trauma screening should be relevant to casework, to child welfare practice. Shouldn't just be a way for them to identify mental health needs, but also a way to inform their CPS practice and their case planning. We heard from a lot of folks that anytime something was suggested, it typically wasn't done, so that we needed a simple, brief tool that could be that was mandatory. And then, as Marilyn said, we heard a lot about secondary traumatic stress, and if workers were going to be asked to have these conversations with families and with children, that it was going to have an impact on them, and it already has had an impact on them, and so that we needed to do more to address their needs as well. And one of the goals of our ACF grant is really to connect children learned with the trauma-focused EVPs, and we learned that child welfare staff in general had little knowledge about EVPs like trauma-focused EVP that were available in their community. Next slide, please. So we are still in the process of developing a screening tool. We have completed several iterations of pilots, and at this point, we are looking to do a screening tool that would be in ongoing services initially when the case was opened, and then at 6-month reviews. We are working to embed whatever tool we end up with into the SACWIS system, and to provide some automatic recommendations for workers about what's indicated or needed for children once the tool is complete. And then to make a standardized behavioral health referral form and linkages to the community providers of trauma-focused evidence-based treatments, so that is all embedded within the SACWIS system and as seamless as possible for workers. Next slide. So we've completed 3 pilots right now of various iterations of the trauma screening tool. We're just underway with another cohort of child welfare staff who are participating side by side with our providers in trauma-focused CBT learning collaboratives and piloting the tool. And at the last group of those workers found that they really valued the tool. They felt like it assisted to engage families in their CPS work, as well as learning a variety of new information about children's trauma exposure and trauma reactions that they hadn't known about, even among workers that had been working with families for quite some time. They often discover new information. So I'm going to turn things over now to Cindy Crusoe, who's going to talk a little bit about our evaluation.
Hi, good afternoon, everyone. So I'll tell you a little bit about our evaluation, and then I'll turn it over to Christian Connell, who's the PI on the evaluation. We'll talk about some of our evaluation milestones and highlights thus far. So the project consisted of a 1-year planning phase and a 4-year implementation phase, each with required evaluation activities. In the planning phase, we're required to assess the system level readiness and capacity for trauma-informed care. And what this means is that we needed to formally assess how trauma-informed the child welfare system was at the time. We also needed to assess the readiness and capacity of the system to provide trauma-informed services and supports to children and youth. And what this involved, really understanding what factors are important to the successful implementation of a system of care, and helps the system assess its strengths and weaknesses and supports technical assistance efforts. There was a key emphasis on the ability of systems to implement evidence-based practices or treatments, and this was a part of our assessment. In the implementation phase, the evaluation is comprised of 3 different components: the process, outcome, and cost evaluations. And with respect to the process evaluation, it documents implementation of concepts components. It assesses fidelity of implementation and identifies facilitators and barriers to implementation. And more specifically, we track things like attendance at meetings and at trauma trainings, and also learning collaborative clinicians collect data that documents what was provided to whom, and they provide ratings of fidelity to treatment models. With respect to the outcome evaluation, we assess the effects of workforce development initiatives and evidence-based interventions that are and will be implemented. Additionally, the outcome evaluation assesses change in system-level readiness and capacity to implement trauma-informed services and supports. With respect to workforce development, we assess the impact of learning collaboratives that are and will be implemented to increase the capacity of the system to provide those evidence-based interventions. We assess outcomes of these learning collaboratives as it relates to trauma-related knowledge for those who participate in the learning collaboratives. And this would include clinicians, DCF staff, child welfare staff, and also family partners. second, with respect to workforce development, there's a 2-day trauma training that was rolled out this year for DCF staff, which represents a significant workforce development initiative within child welfare. And we're evaluating outcomes, which include pre- and post-training assessments and 3-month follow-up assessments that look at knowledge and practice change. With respect to effects of the 2 evidence-based interventions, providers collect data to help assess child mental health and related outcomes. Finally, we'll replicate the systems-level readiness and capacity assessment every year or every other year to monitor change along key readiness and capacity domains over time. And the last component is the cost evaluation, in which we seek to determine what are the costs associated with delivering concept components, including the learning collaboratives. And I'm going to turn it over to Christian Connell, who will talk a little bit about milestones and findings.
Yep. So I'll just go through this really quick, just to touch on some of the key highlights that we've accomplished so far with this, the concept project. Cindy alluded to the planning year activities and the trauma readiness and capacity assessment, and that was really one of the key activities that we took on during the planning year. We surveyed or identified a sample of almost 500 DCF staff and workers, and surveyed them using a tool that was actually developed in conjunction with the Project Broadcast in North Carolina, and also did a parallel set of focus groups with 10 different stakeholder groups across the state representing child welfare staff, providers, and caregivers to basically get a sense for what the capacity of the state was, or the child welfare system and provider community at the beginning of the concept implementation process. The survey and focus group process identified or highlighted some strengths within the child welfare system, including the training academy's role in providing education and training to DCF staff, as well as basic knowledge of trauma practice at the caseworker, supervisor, and provider level. Also highlight some areas that needed further development, like collaboration across systems within the state. And then finally, some areas that represent a more significant need for the state, including a greater focus on cultural competence issues within the trauma context, and the need to focus on secondary traumatic stress, which initially hadn't been a part of the concept project initiative, but was added during our implementation phase, I think as a direct result of some of the information that we gathered during the planning year. The second milestone of the planning year was obtaining access to critical administrative data systems, including our state SACWIS system and other community-based systems, so that we could identify and better refine our understanding of the needs of children and families, particularly services, yes, but as well as other community-based provider networks, and help us focus our planning efforts to deliver the evidence-based practices in the implementation phase. Key milestones from the implementation phase have been the implementation of longitudinal data collection, particularly focused on the toolkit. About 450 managers and supervisors completed the 2-day curriculum for the NCTSN toolkit in the spring. And we've got a pre, post, and 3-month follow-up survey that's been implemented. The initial focus has shown significant gains in trauma knowledge and trauma-related practice. And the preliminary findings from our follow-up show that those are maintained over time. We're really excited about that process. We're replicating that survey process with about 1,200 DCF caseworkers and frontline staff who are just recently started the 2-day curriculum. Another key milestone has been the collection of pre-post survey data from learning collaborative participants, so about 100 individuals, including senior leaders, supervisors, therapists, and child welfare staff, as well as family partners, participated in the first cohort of 6 TFCBT learning collaborative sites, and we've collected a tremendous amount of survey data and qualitative focus group data from that process that we're in the midst of analyzing. We're also just starting to replicate that with 6 new cohorts that are starting this week. In addition, we've been able to successfully implement data collection from TFCBT sites after they complete the learning collaborative, so we've got metric data coming in about the provision of TFCBT to document its implementation and fidelity, and we're also collecting longitudinal child and caregiver assessment data through that process so that we can look at changes over time. And I think with that, I'm going to turn it over to Marilyn for sustainability.
I think it is most fitting
seeing that we have this slide last, one of our most critical responsibilities is to assure that all the work that we are doing under this grant is institutionalized in the very fabric of the child welfare system and the broader community at large system of care. So we have, this is a list of all the various current infrastructure that we're using to make sure work is ongoing and continuously improved. For example, we have trauma-informed care is everyone's job every day. We've already embedded this in our mission statement, our guiding principles. Trauma-informed care is one of our 6 cross-cutting practice themes. It's a core component of our Strengthening Families Practice model. We've written and been sharing a trauma-informed care policy and practice guide. And as I mentioned earlier, we're continuing to do an ongoing review of relevant policies and practice guides. The DCF Training Academy, which is a statewide centralized training group, has already taken over and assumed responsibility for child welfare trauma-informed training, both new workers and seasoned workers, and they plan to do advanced trauma training. We are committed to having whatever trauma screen is finally designed to be embedded in our SACWA system, so it will continuously feed the findings from the screen to our case plan, and whatever assessments and treatments a child needs must be monitored and tracked until they are completed. We have also added specific trauma screening questions to the administrative case review, Child and Family Service Plans review, which is our federal requirement. This is an additional quality assurance safety check to see if it's been done, what are the problems. We continue to use our trauma champions. We have at least 2 or 3 individuals in each area or office in our facilities who, on a voluntary basis, serve as ambassadors, and they're continuing to promote advancement of trauma knowledge and how do you apply that knowledge to case practice. They work in partnership with our worker support and wellness groups, who are also at every spot throughout the state agency. These folks are continuously focusing on activities to promote self-care of the workforce. We also are working to assure that there is some type of regional implementation team that includes the broader community, not only to assure that the work is embedded, but that the problems that arise are addressed. And, we have various groups that are now coming together in an even more collaborative fashion, such as our clinics, who have the TFCBT teams with our child welfare cohort to, again, continue what has begun. Additionally, I'm really pleased to say that we continue to look for ways to blend and braid our funding. So this includes the use of some of our mental health, our federal mental health block grant funds, blended with our state fund to continue to disseminate trauma-specific treatments such as TFCBT, and we'll be identifying new evidence-based practices. We just recently are now beginning to bring on board the modular approach to treatment for children with anxiety, depression, trauma, and conduct disorders, which has a trauma-specific module in it. So that sort of sums up where we are.
Okay, thank you so much, Marilyn, and Jason, Kristen, and Cindy for giving your presentation on Connecticut. I know that we are past our time, but I do want to at least see if there are any questions, comments from those who are still on the call. If you have any questions, please, you can *6 your phone to unmute it. If you have any questions to ask our 3 panelists for today. I know okay. Just trying to make sure. I know I had one question, and you did touch on it, Marilyn, about sustainability, because it's great that you all have this 5-year grant, but what will happen after the 5-year grant, and how can you all sustain it, or will you be able to sustain it, let's say Montana or North Carolina, after the grant is over, and how well have you all planned for that perspective?
It's an ongoing process. This is Marilyn. And, because child welfare agencies are so dynamic and ever-moving and always changing, it's a real challenge. I mean, to give an example, we now have a department-level assessment work group that is looking at all of the various assessment and evaluation tools that a worker must complete, such as our structured decision-making tools, domestic violence screens, substance abuse screens, now trauma screens. So we're all working together to see if we can come up with some kind of comprehensive, integrated assessment package, for lack of a better word, that incorporates all of these screening needs in an integrated, streamlined fashion, so it's not a burden the workers. And I think that what the challenge is.
Sorry. Jim, you were getting ready to say something. Excuse me.
Yeah. Thanks, Sharon. This is Rick in Montana. I'm sitting next to Jim. We were making notes while the microphone was muted. I think what's I'm really appreciative of hearing about the state level systems and how things are being implemented as policy and requirements to ensure that workers comply with the mandates of administration. And our system is a little bit different because most of what our conversations regarding sustainability have been with our partners have been starting out from phase one with the needs assessment and trying to make sure that we're being very responsive and aware of what they perceive their needs to be. And we don't always see that exactly eye to eye, but usually we're able to find some common ground where they are able to articulate something that they need to do differently that represents a more trauma-informed practice. And moving toward that objective, I think, well, ultimately it'll be an empirical question. I think the likelihood that some of the innovations and transformations we're attempting will be sustained will be driven by the fact that what is happening at the local level and regionally are new practices that were requested by the people who have been charged with performing those duties.
I don't know if Jeannie is still on the line. Did you want to answer that question as well?
Sure. You know, I think it's part of the others. I mean, it's just really embedding it. You know, we've been family centered now for many years, and that's been kind of part of our culture. And it's moving towards kind of family centered, trauma informed, so that everything is really embedded. And I think the more you can make it second nature, and the more it's embedded in all the training curricula, and we're fortunate that our General Assembly has allocated funding to continue to support the North Carolina Child Treatment Program from the mental health side. So we're very hopeful about sustainability. So we'll see.
Good. And then let me just ask one more question. I just wanted to know, what would you suggest for those states who may not have already have this implemented? What would you suggest? And they're not getting funding, obviously, but what are some of the suggestions you would have as far as how they would have to collaborate with some of the other systems out there? I'll start with you, Jeannie. How about that?
Yeah, I think that you hit on the right word. I mean, it is collaboration. I think we have often given that word lip service in the past, and I think that for this to truly be part of our culture, it is really sitting down with the mental health partners and other really community stakeholders and making a meaningful collaborative effort. And as part of this grant, we've got some readiness tools that we can share, and you know, certainly all the products from NCTSN can certainly help them along the way. So,
well, anyone else?
Hello, this is Jim. You know, I would echo what Jeannie just said about the tremendous amount of resources that are at the National Child Traumatic Stress Network and that are growing every day, and just how exciting it is that, you know, trauma is being recognized for what it is and the importance that it has. When I think of specifically our work in Indian country, I would say that looking towards the existing strengths within the communities is essential. I'm sure that's true of all the communities that we work with, to see what's already there that can be built upon.
Well, just want to make sure if anybody have any questions or any comments. If not, I will be sending out the slides and you'll be able to contact Jim and the others if you have any questions about their project. I want to thank you all again for being on the call, and you all have a wonderful, wonderful day. Thank you.
Thank you. You too.
Bye-bye. I didn't know that you have to have this. Why would that make a difference? Okay, how you hit stop? Stop recording? No, let her. I'm like, let me move out the way. Let her. I would say anybody gets done. I didn't know that. It's still recording.